Welcome to EP Talk. I'm your host, Mark Plaster, and my co-host and major presenter today is JD Landon. And JD, thanks. You came up with this study that you wanted to talk about, and the more I read it, the more I looked at it, the more excited I was about hearing this interpreted by an ultrasonographer like yourself. To set the stage, though, I think that we need to talk about this study is about the sonographic protocol for emergent evaluation of aortic dissections. It's called the SPEED protocol.
It's a great name. SPEED protocol. They nailed it.
Isn't that the truth? Okay. That's the nightmare of many ER docs is an aortic dissection. And how quickly can you get to it? Can you make the diagnosis before the patient decompensates? Will they decompensate in the CT scanner where you're not there and they only got a tech? I think that we all have a story or two. I'll let you go first, and I'll tell my story afterwards. But you said you had an example of this.
Yeah, Mark, I hate this diagnosis. Aortic syndromes are, I think most emergency physicians, they're such high risk. The mortality is so high in these patients. And
50%.
And there's no perfect presentation. Like all these studies we've all looked, what are the perfect things? If I just know this, and this, and they don't have these things, then I can be sure it's not the case. My first aortic dissection, of all the ones that I probably have missed and sent home, right? Because this is often a diagnosis that isn't found until the second or third evaluation, was a guy who came in with anxiety. And it was like he had, and you know what the craziest thing is? It wasn't like, oh, I'm really anxious today, but no real reason. The guy had like 4 reasons going on in his life, like that he should be anxious. I was anxious for him, but he just wasn't quite right. He's a little bit diaphoretic. And we ended up actually finding a flap on ultrasound. The
fact that you ultrasounded him is actually pretty unusual. I mean, it's because you liked ultrasound, right?
Well, it was because we were...
It was a hammer in search of a nail is what it really was.
It was because we were like, what is wrong? Like, we felt like, the gestalt, there was something wrong with this guy. We had no idea what was wrong with this guy. So we're like, I don't know. We just ultrasound him and just see what happens.
Look around.
I mean,
right.
It was pure shotgun.
You got the first right. You got the first question right. Sick versus not sick.
And
I'm serious. I mean, sometimes that's the hardest part is sick versus not sick. And once you know he's sick, you look until you find it.
This guy gave me nightmares because I was this close. We were this close to sending this guy on his merry way, being like, here's some Ativan for your severe anxiety. And I think that gets to the point, right? The incidence of aortic dissection is extremely low. Some places are reporting, 0.3% of our chest pain presentations. And so just insanely low. And yet, this gentleman, even though he was in the OR, once we made the diagnosis, he was in the OR within probably 6 hours or so. He had passed away within 48 hours of presentation to the emergency department. And the mortality rate on these is so high. Mark, what's your story? I know you got a good one.
Well, actually, I have to. I'll tell you what. I reported from my internship on Tuesday, and we still have wards where all the men you'd have 12 men in a big giant room, and the second year resident was rounding with us, and one of my patients sat up in the bed, groaned, and fell out on the floor of the bed. It fell out of his bed into the floor. So I had, and the second year resident looked at me and said, "Plaster, what's going on with this guy?" And I said, "I got here yesterday, day before yesterday. I don't really know too much. I just got out of medical school." And no, it was the chief said that. And the second year guy said, "I think he has a PE." And I said, "That sounds good to me. Let's load him with heparin." And we loaded him with heparin as he bled out into his abdomen.
Oh, man.
Man. The one that when you asked me, the one that I thought of, though, was a young kid in his 20s, incredibly healthy, came into the emergency department and had flank pain. Thought for every possibility that it was a renal colic, and didn't see a stone. Kept studying. Got a CT. Didn't see anything at all, but he had excruciating pain. Excruciating. Took slugs of morphine to help this kid, and he was not a drug user, and his family was there. They were frustrated with it. The ER doc was looking, and the radiologist said, "We don't see anything going on here with his aorta." And after being in the ER about 6 hours and having excruciating pain, more and more morphine, ER doc, who good friend of mine and a very, very responsible guy, went back to the family and said, "I'm sorry, we need to scan him again. We need to look at him again." And the parents said, "No, we don't know what's going on here. You obviously haven't figured out what it is." And about 30 minutes later, he crashed. And it was an aortic dissection that they hadn't seen in the first round. And of course, there's nothing they could do. And I came to this. I came to this case as an attorney because the family came to me and wanted to sue the ER doc.
Wow.
And I was who they turned to as a plaintiff's attorney, and I went in and looked at it, and I said, "I don't see how this guy made any mistakes at all. He didn't find it, but he had the chutzpah to tell the radiologist, 'Go do your work again and look again,' and the family overruled him."
Wow.
Yeah. So then, and I talked him out of suing the ER doc, because I thought that he did everything he could have. But that's the frustration that you're talking about here, of having unusual cases. It turned out that he had a connective tissue disorder. It was an Ehlers-Danlos kind of variant, that he didn't have all the neck, the elastic skin and all that, but nevertheless had aortic tissue issues, and so it just blew apart. Boom, blew apart, and he was gone.
So this, that more than anything, that's an unbelievable case. Demonstrates why really any tool at our disposal that might increase our sensitivity to this diagnosis is welcomed.
Absolutely. And the thing that absolutely puts everybody in fear, though, is if you think they've got it and you're going to take them to the CT scanner, and in a lot of ERs, maybe the top level ERs, the CT scanner is really close by, but I worked in a lot of ERs where the CT scanner is not close. In really small places, it may be in a truck. And, so you're going to take this guy that you think is kind of marginally unstable and take him I worked in a place that I had to go essentially across the street and with them. And so if they crash like that, it's horrible. So what is the speed protocol and why is it important? So we've kind of set the stage here. So tell me a little bit about what the speed protocol is.
Yeah, so this is a recent article put out in the Academic Emergency Medicine Journal just recently in 2024. And they looked at three ultrasound views.
First off, let's give some credit to the investigators. Ryan Gibbons, Dylan Smith, Rivka Feig, and Molly Mulfleur. And Thomas Constantino. So anyway, I just want to give a shout out to those guys for a very, very good study. I think this is a original article for AEM and is worth taking a look at. So take off.
Absolutely,
tell me about the speed protocol.
And so it was a multicenter prospective observational study. Looks like these guys were from Winchester, Virginia, out of Geisinger, out of St. Luke's Hospital, out of Temple. And so it was an awesome group of people come together over 10 years. They did a total of 1,314 scans of this protocol. And the thing I really like about this protocol is it's a relatively easy protocol. Because as we always talk about, Mark, not everybody goes to fellowship, nor does everybody need to go to fellowship. But they looked at three.
Well, we differ there. I actually think that's I actually think that everybody in emergency medicine needs to have a very high level of proficiency in ultrasound. But that's you're being modest. But that's where I think we need to go. So go ahead.
And so they looked at 3 things, and these were all with transthoracic echo. The first one was on a plaques view, your kind of standard first view, parasternal long axis, looking for pericardial effusion, right?
Okay.
Same stuff you might look on a FAST or EFAST exam. So that was first. Number 2 was looking at a dilated aortic root. Oh, I'm getting bubbles. I didn't do that intentionally. So the second one is aortic root dilation or the left ventricular outflow tract. And so they're looking for an enlarged size there. So it's basically using these calipers on every ultrasound machine to get a measurement above, looking for something above 35 millimeters or 3.5 centimeters.
So assuming that a partial obstruction of the aortic outflow tract will cause dilatation of the aortic root or the outflow tract. Is that the idea physiologically?
Yeah, that's the basic idea. And obviously this is always going to depend on where exactly the flap is, how long it's been there, whether thrombus is developing there. But what they basically done retrospectively on all of them is basically said, if the root is smaller than 35 millimeters, it's a very, 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 very small group of people who have dissection with a small aortic root or left ventricular outflow tract.
Okay.
So that's the second one. The third one is basically an intimal flap. So if you can see a flap on the ultrasound anywhere in the aorta, obviously that's going to be a positive finding. And what's particularly great is that if you get lucky enough to see a flap and you're out in the middle of nowhere or you think they're too unstable to go to the CT scanner, that's when you're making your call to your vascular or CT surgery team, maybe transferring them just based on your echo and foregoing, and maybe once they're stabilized at the tertiary quaternary care institution, then you get your CT scanner when you've got all the fancy bells and whistles.
Right.
So it's an interesting study. 1,314 protocol exams is pretty good. And we'll just jump right to the conclusion here. And so they found that they developed an overall sensitivity for aortic dissection of 93.2%.
Well, before you get to that point, they diagnosed 21 Stanford A's and 23 Stanford B's. That's pretty significant. That's 44 cases that they diagnosed in the ER. And now the reason why that your 93% number is so important is they had a 93% sensitivity, even if you went ahead and sent them to the CT.
Right. And so, and to be included, obviously, in this prospective observational study, you also had to have a CTA or an MR for the final gold standard diagnosis. And that's how they were basically assessing this protocol to see how accurate it was. So just kind of on first blush, 93% is pretty good sensitivity. Obviously, missing 7% in this, this high risk of a diagnosis is not acceptable. But when it's a diagnosis like this that is so hard to find and where we can't be sending everybody to the scanner who has unusual chest pain, it's an exciting adjunct to at least consider.
Well, it actually, if you miss it here, and particularly as in the case where I told you about the young man who had the dissection that the radiologist missed it on the first pass. And these are the flaps sometimes collapse, and they're there and then they're not. And it's when something catches it and opens it up, and then it dissects all the way down and then breaks out, is when the patient collapses. And there's just a certain number of those you're not gonna see. The fact that you could see 93% of them, I think, is pretty good. It is very, very good. Now, but before you go further into it, I want you to. We talked before the podcast. You were saying that there may be a little bit of a selection bias here because the way it's set up. It's not necessarily a criticism, just an observation that sometimes your best sonographers, your attending. This was set up as a first, second, third year resident with an attending kind of directing their movements. Is that right? Did the actual scans were not done by the attendings? The actual scans were done by the residents. Is that correct?
Yeah, and I actually think you could make the argument that actually might be a strength of it, right? Is that, they specify in here these were PGY1 to PGY3. They all had about 4 hours of didactics coming into their intern year, and then continued education, but not, like, again, I said before, not necessarily an overwhelming amount of specific training.
Yeah, not ultrasound fellows.
Correct. There's plenty of papers where it is usually ultrasound directors or fellowship directors or fellows that are doing.
And that's kind of a turn off to the average clinician. Oh, well, yeah, that's great for him, but I don't have that kind of skill. I'm not able to do that. And what the point here is they took the babies, the interns, and with a couple of 3 or 4 hours of training, and could help them make this diagnosis upwards to 93% of the time, which is pretty good.
Which is pretty good. And, one of the clear limitations, and they talk about this in their own discussion section here in the article, which obviously we recommend everybody check out, is, it was a convenience sample, right? So if the research assistants weren't there, or if the ultrasound folks who were really probably most interested in doing this study over that 10 years weren't there, the entire protocol and the way you got included in the study is just if the physician thought that there was a high enough pretest probability for dissection and they were interested in doing an ultrasound on top of their CTA or whatever imaging they were doing.
So they had a little bit of a positive selection bias to start with. If you know what you're looking for, you find it many times, more often than not. So they're not completely blind. They're not just randomly scanning people. But
and then, and you have to ask the follow-up question, right? Is their prevalence was quite high, right? So it came out to about 3.3% of the cases that were included ended up being dissections, which is impressively high. And so the question is, well, is that really? Are you going to expect to see that kind of percentages at your shop, right? Is this really generalizable or applicable to other shops out there? These are all, I think, reasonable limitations, reasonable criticisms. But overall, I think it's a great paper, really strong work. And certainly the hope is that we'll get replication of these results at other facilities, at other shops.
So let me summarize then. Okay, so we've got a study here that there were 1,314 exams, and they diagnosed 21 Stanford A's and 23 Stanford B's, and had a sensitivity rate of 93%, which is pretty good. They, if you added in TEE and D-dimer and MR, you only got up to 95%. So that's a pretty strong recommendation for the SPEED protocol. So if you don't mind, I know you've got some images here. Why don't you pull them up and let's talk about them?
Yeah, so we're gonna jump over to ultrasoundidiots.com.
I love that.
This is a good friend of mine, Dr. Matt Jones, who's our ultrasound fellowship director at Eastern Virginia Medical School. Amazing guy, really wickedly good with the ultrasound probe, and he's been building this website. Can you see that there?
Yep. Mm-hmm.
He's been building this website,
and you got your cursor without the little stars around it, so that's even better.
Nice. So yeah, it's Ultrasound Idiots. It's the website designed to be an open educational resource for the clinical application of point-of-care ultrasound. And so he's got great stuff here. I mean, you could spend all day if you wanted to learn or just review images. Really awesome work that he's done here. And then there's this little secret. This period actually becomes a link, and he's told me I could tell you guys this secret. And if
I see it down below.
If you click on it, it will actually take you to the emergency medicine ultrasound program, of which I am a graduate and highly recommend. And it's basically all the awesome lectures and stuff they're doing. So I asked him, I was like, "Are you sure?" A lot of really quality stuff out here. But he said no, he's just trying. He wants everybody. He's preaching the gospel of ultrasound. So
that's great.
We are going to steal some images from his website today to talk about aortic dissection and the SPEED protocol.
That's great. Okay, good. Outstanding.
So I just pulled a couple clips. Let me go ahead and make this bigger so hopefully you can see it clearly. Can you still
There you
see
go.
that okay?
Yeah.
So in the speed protocol, like we talked about, really, there's only really 3 views and 3 specific things they're looking for. One is a peristernal long axis looking for pericardial effusion. On that
Okay.
peristernal long axis, you're also going to look for the diameter of the left ventricular outflow tract or the aortic root to see if it's dilated beyond 35 millimeters. And then you're going to switch probes and go to a curvilinear probe in the abdomen to do a short view and a long view of the descending aorta. So here's a couple examples of what that might look like.
Now see what, I like the acronym, but I can also see that it is relatively quick. It is relatively quick, so speed is appropriate.
Yeah.
So what are we looking at?
So here's our peristernal long axis. And so in this view here, I'll forward it right a little bit further. So you're seeing the left atrium here, left ventricle is this chamber here. This whole space here is where you're considered your left ventricular outflow tract going into your aortic root.
Okay, and show me the aortic valve. Okay, we're in that bunch. Oh, okay, I see it now.
Right through here. It's not a perfect view. I kind of like this because it's not. Oftentimes,
I think
we don't get perfect views.
I think the aortic valve.
So here's your mitral valve here, and this is so you've got blood here going from the the left atrium into the left ventricle, and then your outflow tract is your blood is going out through here. And so right in this space, you can't see it beautifully on this image, but in this space, you have your aortic valve here. What this view or what this image is helpful for is to show you a pericardial effusion, which you can see is circumferentially wrapping around the heart here. And the tip or trick of this is to always check to see if the fluid looks like it's going underneath the descending aorta, which is this hypoechoic structure here, or is it going over top? If it's going underneath, more likely to be pericardial effusion. If it's going over top, more likely to be pleural effusion. Sometimes you have both, and all you see is this thin pericardium to define the 2 layers.
Now, I know you're the ultrasound Bubba, but I think that I don't have your cursor, but I think the aortic valve is much deeper. It's I think you pointed to it much too high. I think it's right.
So the best view, if I can pause it somewhere.
I think it's right adjacent to the.
So right here, you're starting to see a little bit of graying here. So this would be the annulus for the aortic cusps. And so here, you obviously, this view is not.
Okay, so you're going to, when you measure it, you're going to measure beyond the aortic valve, correct?
Yeah. So, and we got a better view on another shot here. But this particular clip is just more so demonstrating the pericardial effusion.
At the pericardial effusion. Okay, so this is not the best one to look at the ventricular outflow tract. Okay.
So let's go then. So this is just another demonstration of pericardial effusion here.
Yep.
So this is an apical 4-chamber
Even I can see that one. Yep.
And then you can see this would be your left ventricular outflow tract here with your aortic valve, and this is almost a full 5-chamber view because you can see the aortic valve cusp coming in and out there.
Okay.
So then next, we've got another peristernal long axis. And so this is where you can see, Mark, where they've kind of rotated to focus more on the aortic valve and the aortic root in this, right? Mm-hmm. So in this view, right, the left atrium is here. The left ventricle, you can barely see the whole thing, right? So the left ventricle is all this space here. So they've kind of rotated to focus on the aortic valve. And you can see the aortic valve cusp coming in and out here, here and here.
Got it.
And then you can see, so this is your sinus of Valsalva, and then so this is where they would be measuring. It's just distal to the sinus of Valsalva. This is where they would measure. And if you look closely enough, you can actually see in this shot a little intimal flap right there.
Yeah, you sure can, can't you?
It comes and goes. And a lot of times, this is one view, but a lot of times if you think you see something, one of the best ways to try to see if it's an artifact or if you're just, hallucinating is to try to see it in different views. So kind of rotating or panning or just trying to look at a slightly different angle to see if you can get a better view of it. But this would be an example of a dilated aortic root. So moving on. This is
the one.
this is incredible. I mean, this is just an incredible shot. So this view now, you've switched over to a curvilinear probe, and this is now in a sagittal.
Heart is to the left, correct? Heart's to the left.
Correct. Heart's to the left. You're looking through the liver here. So this is all liver here, heart's here, and so this is your aorta. This will be your celiac. Your first takeoff of your celiac, followed by the SMA. This is your left renal vein coming underneath your SMA.
So which is the false channel there? It's so huge. I guess it's the one on the back, huh?
Who knows? I don't know. My guess would be here, but I mean, again, it's like, how do you really know? So,
wow.
But it's a beautiful shot, and again, right, you can acquire this image quite quickly, and this is a part of their speed protocol. So once you did your peristernal long axis, switch your probes, come down into the abdomen to get this view. The other thing I'll just notice, if you're wondering what are these kind of hypoechoic bumps down here, this is actually what we call the spine shadow. And so this is a relatively thin patient. So the other view then is you just basically rotate the transducer from the long view that you just had to the short view. And so now here is our spine with our spine shadow. Here's our liver, IVC, aorta, and then look at that. This is what your intimal flap's going to look like.
So that's why the pain's going through to his back, is because that flap is in the back.
It's right there. And so, I mean, and that's the protocol, looking peristernal long axis, switching the curvilinear probe, and you're looking for 3 items: the pericardial effusion, the dilated left ventricular outflow tract or aortic root, and then looking for an intimal flap, either up high, right? Because we saw that one view where we start to see the flap up high, or down lower in the abdomen, looking for it.
Yeah. I can see that the measuring the 35 millimeters would be difficult for me, but I can see this. And I can see the flaps, and I can, I could see the pericardial effusion.
Yeah. And I mean, I would say, 5 seconds with me with an ultrasound probe, and you'd be ready to go measuring the caliper. And one little side note is, whenever we're measuring the aorta, whether looking for aneurysm, or anything dilated, we're always doing sort of outer edge to outer edge, the reason we do that, right, is you want to always if you're going to be off, you always want to be a little bit over, if that makes sense. So you don't want to be measuring just the black. You want to be going outside of the edge and make sure you're getting the entire wall.
Wow.
And so, again, this study has plenty of limitations. Obviously, I think maybe the convenience sample being the biggest one. But I think, like we talked about, when we're talking about a diagnosis that is very low prevalence and very high mortality, anything to add to our tool belt, to increase our sensitivity, I think is worth considering. And so I'm hopeful that we'll get follow-up studies from other institutions to confirm some of the quality of this protocol, but I think it's definitely something that I'm at least going to consider in the future.
I'm just looking at their flow chart. I was looking where they had 1,314 patients, 1,314 patients, of which 156 had positive sonographic findings, and then they found 21 Stanford A's and 20 Stanford B's, and then 115 but just had pericardial effusions. And then on the other side, which is just as important, they had 1,158 without positive sonographic findings. And out of that group, they only saw 3 Stanford B's and 1,155 without any aortic dissection. That's obviously a very good. You take a big, deep breath when you don't have any of those 3 findings. It doesn't mean you don't go ahead and get the CT, but it puts them in a much better risk group for sure.
And I would say too, when if you dig into the details of it, the one case that was a B that was technically missed, that actually or was deemed, the interpretation was deemed to be negative. There weren't actually follow-up images for QA. So nearly all of these images were QA'd, right? So they got saved to some sort of QPath or some sort of system. And then the ultrasound folks were able to go back and look that one. So I say that in that one type B, it may have been there, and they just missed it, maybe just for experience or whatever.
Or like the case I was telling that we started off with, talking about the young man that had unexplained severe back pain that the ER doc thought for sure was, something vascular and couldn't see it. And they happen. The point of it is that they happen. Okay. Yeah. Sometimes those flaps close down and you look at them and you can't see them and they open back up and then they enlarge and they go back down again. That's a nightmare, but, and then unfortunately they do happen. So thanks. And I want to give if I haven't already, I want to give a shout out to Ryan Gibbons and Dylan Smith and Rivka Feig and Molly Molfleur and Thomas Costatino. You guys did a great work, and I think that the speed protocol is one that's worthy of everybody looking into. If you're not an ultrasonographer at this point, like me, it would behoove you to learn how to do those 3 views. My gosh, you can save yourself some huge problems. Good study. Thanks for the review, JD, and check it out on Academic Emergency Medicine, AEM, and take a look at it yourself and see if you have other observations, questions. JD can probably answer them or route them to the right people who can answer them, and hopefully we'll put a little speed into the diagnosis of aortic dissection.
That's right.
Everybody, thanks a lot. Thanks for joining us, and join us again on EP Talk.